Good afternoon, everyone. So today we are going to discuss again a stone scenario in FRCS Viva practice. We have got a trainee with us who has agreed to record this. Many thanks for that. So without any further ado, we'll straight go into the clinical scenario. So you are receiving a referral letter from GP. 32-year-old lady. She already had 3 operations in the past 3 years. Your team did a right URS and laser clearance of stone 3 months ago, and then the plan was to review in 3 months' time. However, she had intermittent pain in between, and she contacted her GP, who sent this urgent referral. So, how are you going to proceed?
So I'll arrange to see this patient urgently in my clinic in terms of the triage, and I'll assess her by first taking a focused history, asking about the location and duration of her current episode of pain, any radiating features, the severity, and associated symptoms such as vomiting, fever, rigors, visible hematuria, and any lower urinary tract symptoms. I will confirm her past medical and urological history, including the operations she's had and the routes. I will establish the medications that she's on, as well as family history of renal stones, and I'll also establish her occupation if the pain's had any impact on this. I'll then perform a chaperone physical examination, measuring a urine dipstick analysis in clinic, and I'll look to elicit any abdominal or loin tenderness.
Okay. So, what are the investigations? Because she's a recurrent stone former. What are the investigations do you specifically want for her?
Given that she's got recurrent stones, I'll request serum blood tests through a baseline urea and electrolytes, and serum calcium and uric acid. I will also request a 24-hour urine collection. Given the recurrent intermittent pain that she's been getting, I will also request a CT-KUB.
Okay. The CT-KUB shows picture of nephrocalcinosis. What are the causes of nephrocalcinosis?
So this can be caused by primary hyperparathyroidism, renal tubular acidosis type 1, and also keeled pillary necrosis and TB.
Okay. So because she is a recurrent stone former, do you do any special investigations?
So I've mentioned earlier that I'll request a 24-hour urine collection. Given that the CT findings are suggestive of nephrocalcinosis, then I will consider testing for renal tubular acidosis, and I'll arrange this by referring to my colleagues in renal medicine.
Okay. What's the importance of reviewing the previous stone analysis?
So this will help to determine what the underlying stone composition is, and whether any further investigations are needed, if the patient can be treated with medications, but also if they need to make any dietary adjustments.
All right. What all things will you look in the 24-hour urine collection, and how do you do it?
So I will provide 2 bottles to the patient, one with acid and one without acid, and I will advise them that they need, over a 24-hour period, over 2 24-hour periods, they need to void each time into one of the bottles, and discarding the first early morning void, but including the next morning's void after they've woken up. I'll provide them with the labels and forms to then provide the bottles and samples to the hospital pathology lab, and I'll be on the request. I'll look specifically for the urine volume, pH, and urine levels of calcium, phosphate, oxalate, cysteine, uric acid, and citrate.
Okay. And what are the general preventive measures that you advise for recurrent stone formers?
Sorry, the dietary measures.
General preventive measures. Sorry.
So, as per the NICE guidelines, I will advise such patients to maintain a daily food intake of between 2.5 to 3 litres, to avoid carbonated drinks, whether they can add lemon juice to drinking water, and I'll also advise them to maintain a dietary consumption of animal protein and salt in moderation, and that the dietary calcium needs to be between 0.8 to 1.2 grams a day, and a dietary sodium of less than 6 grams a day.
Okay, well done. So you are reviewing this patient's urine dipstick and it shows a pH of 6.8. The stone analysis shows predominantly calcium phosphate stones, and the 24-hour urine study shows high pH and hypocitraturia. What do you think is the probable diagnosis here?
I think the diagnosis here is a type 1 distal renal tubular acidosis.
Okay. What are the causes of calcium phosphate stones?
So these can be caused by the diagnosis that I've just suggested. They can also be caused by primary hyperparathyroidism, nephrocalcinosis, medullary sponge kidney, and hypocitraturia, and also medications such as carbonic anhydrase inhibitors.
Okay. So you said that this is a distal renal tubular acidosis, isn't it? What are the types of renal tubular acidosis?
There are 4 types. Type 1 is distal RTA. Type 2 is a proximal renal tubular acidosis. And then there are also types 3 and 4.
Okay. Is type 3 still described?
Not commonly.
Okay. What is the most common form of RTA?
The most common form is the type 1.
Okay. And what is the frequency of stone formation in type 1 RTA individuals?
This would be between, I think, 25 to 50%.
Okay. So how do you diagnose type 1 RTA?
So one of the main means of diagnosis is the ammonium chloride loading test, where the patient is given a loading dose of ammonium chloride at a dose of 0.1 grams per kilogram. They then have the venous gas and urinary pH measured, and if the serum pH is less than 7.3, or the serum bicarb is less than 16, but the urinary pH is greater than 5.5, then this points towards a diagnosis of incomplete type 1 distal RTA. There is also measurement of early morning urine pH, and if it is greater than 5.5, then greater than 6, and this suggests a complete distal renal tubular acidosis.
Okay, well done. And what are the classic findings in type 1 RTA in the blood?
So in the bloodstream, there will be a hypochloremic, hypokalemic metabolic acidosis with a low bicarbonate as well.
Okay. What is the reason that these in distal RTA the stones are calcium phosphate?
The underlying mechanism is that there is failure of excretion of hydrogen ions by the distal convoluted tubule, which leads to a serum metabolic acidosis. The renal compensation for this is to convert citrate into bicarbonate, but this means that there is less urinary citrate to form soluble complexes with calcium, and this therefore can form a soluble complex with urinary phosphate, and this leads to saturation and precipitation of calcium phosphate crystals.
Okay, well done. And is it common to have stones in type 1 RTA?
It's
Sorry,
it is.
I have to change that. Is it common to have stones in other types of RTA?
So it is uncommon. Type 2 RTA is due to failure of resorption of bicarbonates. Therefore, and that's in the proximal tubule. So, therefore, this means citrate is not converted to bicarbonate, and more of it's available to bind to calcium in the urine. And in type 4, there is also stones are not seen.
Okay. How do you treat type 1 RTA patients?
So I'll treat these patients in conjunction in a dedicated metabolic stone clinic with a renal physician, and I'll manage them symptomatically, but also with the aim of preventing future stone recurrence. I'll advise them on conservative measures as outlined before, but I would recommend them on potassium citrate, and this would be with the aim of providing citrate within the urine to stop calcium phosphate from forming.
Okay. What if there is hypercalciuria in the 24-hour urine collection?
If there is hypercalciuria, then I'd screen for hyperparathyroidism with the serum parathyroid hormone levels, but I would commence the patient on thiazide diuretics to enhance excretion of calcium from the proximal tubules.
Okay, well done. So we'll stop there.